Lipedema was first named as a medical condition at the Mayo Clinic in 1940. It presents during hormonal change, such as childbirth or menopause, characterized by abnormal enlargement of painful nodules in subcutaneous adipose tissue. Lipedema is a hereditary disease, and recently the first related gene, AKR1C1, was discovered. It manifests as a connective tissue disorder characterized by hypertrophic adipocytes, inflammation, and dilated leaky blood and lymphatic vessels. It begins to develop in the lower extremities, leading to circumferential bilateral extremity enlargement, typically extending from the hips and buttocks to the ankles. It then progresses to the arms and lower abdomen. Lipedema pain originates from fibrotic nodules and swelling impacting the nerves. It causes joint problems due to heavy tissue stressing the limbs and spine. Even in early stages, it leads to problems with balance, mobility, and an impaired quality of living. Lipedema is distinct from obesity, although patients may be obese. It spares the hands and feet, and patients often have a normal-looking upper torso, even when seeming obese. Reduced caloric intake, physical activity, and even bariatric surgery do not reduce the abnormal lipedema tissue, which likely results from the growth of brown fat cells and lymphatic dysfunction. Conservative measures like compression and manual lymphatic drainage that work to reduce fluid in conditions like lymphedema can provide some short-term relief, but do not reduce lipedema tissue. Women with lipedema are at an elevated risk for developing morbid obesity and often find it difficult to lose weight before lipedema surgery. Lipedema results in hypertrophic fat cells and fibrotic tissue in the muscles that reduces the ability to lose weight. There are published guidelines for diagnosing lipedema. Although there is variability among patients, clinicians look for the following: limbs that feel tight and heavy, especially at the end of the day, even with elevation. Increases in adipose tissue, usually starting in the legs. Pain to the touch and easy bruising. Cuffs or bulges around joints. Negative stemmer sign, in early stages only. Palpable spheroids and lipedema fat. Non-pitting edema and an abnormal waist-to-hip ratio, present only in early stages. CT, MRI, and lymphoscintigraphy are only used when the history and physical exam indicates a low probability of lipedema. Liposuction has been used since the 1940s and has been utilized for non-cosmetic applications since 1982. It has become a surgical tool just like a scalpel. Liposuction is used for benign symmetric lipomatosis, flap undermining or defatting, gynecomastia, evacuating hematomas, and emergency airway restoration. Liposuction is also used to treat hemangiomas, soft tissue necrosis in the ICU, hepatic cysts, and pediatric lipodystrophy. Complication rate for liposuction is very low compared with conventional excisional surgery. For lipomas, surgeons often choose between or combine open lipectomy and liposuction. There has also been a shift from the open approach to liposuction in treating gynecomastia. Liposuction allows surgeons to visualize painful lipedema nodules, which they can then manually remove. This is not cosmetic liposuction, but is a 3-hour stage surgery to remove diseased tissue. Liposuction surgery is not subject to approval by the FDA, and no medical society has determined it's experimental, investigational, or unproven. Lipedema surgery has a definite positive and long-lasting effect. It's the only treatment that can restore normal gait and prevent joint deterioration. A study of 64 patients showed a distinct reduction of subcutaneous fatty tissue, marked improvement in pain, edema, bruising, and an increase in quality of life with no serious complications following surgery. A study of 111 mostly advanced stage patients over 10 years showed a significant reduction in pain and increase in mobility for all patients. Serious adverse events were observed in 1.2% of procedures. The infection rate was 0% and the bleeding rate was 0.3%. In a study of 209 patients, quality of life increased significantly after surgery with a reduction of pain, swelling, and bruising. Requiring controlled clinical trials testing whether lipedema surgery improves pain and function makes trial participants suffer when there is effective existing treatment. Most other surgeries that insurers cover are not held to this standard. Anthem and Aetna, who were sued for not covering lipedema surgery, have now revised their policies to cover it. Aetna has established a detailed prior authorization process. Premier Blue Cross also has coverage guidelines and plans including Highmark, Excellis, and CareFirst that have covered lipedema surgery without external review. Other Blue Cross Blue Shield plans are working on adopting new policies. Medicare, Medicaid, TRICARE, and federal employee programs have also covered lipedema surgery. Covering this surgery would not be too costly. There were less than 1,000 lipedema surgeries last year. Currently, there are only a few skilled surgeons in the US, and even if the volume of surgeries increased 10 or 20-fold, it would not be significant. If lipedema were diagnosed and treated earlier, many other costly procedures could be avoided. Up to 25% of women with lipedema have had failed bariatric surgery. Knee replacements and eating disorders are also common. Lipedema surgery prevents women from losing their mobility and allows them to once again be active, socialize, travel, and play with their children and grandchildren. Even for plans without a policy yet, ensuring a knowledgeable and consistent internal review is essential for members suffering from this disease.